Better health, better care, lower cost. Everyone's talking about healthcare, but how much do you know? Better Health is brought to you in part by Sleep Better Northwest. Explore the healthcare system and listen to experts with your host, Sue Lani Madsen, here on Better Health.
Well, welcome to this edition of Better Health, and my guest today is Julie Akers from WSU's College of Pharmacy, and you are a clinical assistant professor in the pharmacotherapy department.
Yes, I am. Thank you for inviting me. I'm excited to be here today.
Yeah, and I never really think of, or most of us don't think about how clinical pharmacy fits into their lives, and that was one of the reasons for inviting you, is that that's one of your specialties, I believe.
Yeah, I'm excited to talk about the different things that pharmacists can do for patient care in a variety of practice settings, from the hospital setting to your local community pharmacist.
Okay, so you were just at a conference in Nashville where this is pharmacists from all around the country who are gathering to really keep up on what's changing. And there's some highlights from that conference that you'd like to share.
Oh, sure, yeah. The APHA, the American Pharmacists Association, as many of our other pharmacy associations, host an annual meeting. And it's just a great opportunity for pharmacists to come together and from all practice settings and present. There's a lot of great, exciting things that pharmacy technicians are doing. One of my colleagues presented on, did a podium presentation on technicians in Idaho now can actually immunize. Like your flu shot that many of us get at a community pharmacy, it can actually be the technician doing that. So really just seeing some of the ways that pharmacy practice is changing. A lot of the presenters from Washington State were talking about medical billing, because that's one of the new things in the last couple of years in our state that many other states are trying to copy that legislation so that they can medically bill their pharmacist time as well. Yeah.
Okay, so that's a lot in that quick update. Let's go back and kind of start from the beginning, which is pharmacists don't just count out pills at the counter anymore.
They don't, and you know, I know there's, within our profession, we kind of call it count, pour, lick, and stick. And we do so much more than that. That's really just the technical functions of making sure that the patient gets the appropriate medication, you know, with the right pills in the bottle. But really, all pharmacists, regardless of practice setting, are looking at a lot of things. They're looking at the patient's medical history, what disease states they have. If they have access to it, they're reviewing their laboratory data, what's their kidney function at, and then they do a clinical analysis to decide if the medication as prescribed is appropriate. Is it the right drug for the patient? Is it the right dose? Should it be adjusted? Counseling patients on proper administration of different medications and side effects. There's much more that goes into it than just printing a label and sticking it on a product for a patient. Yeah.
So if I've been to a doctor or a nurse practitioner and I've got a prescription and I take it to my pharmacist. Now, I make a practice of always going to the same pharmacy, and I'm sort of assuming that they're keeping an eye on things. I've never asked. Am I correct in my assumption? What should be happening there?
Yeah, so what happens, and thank you for using one pharmacy. We always recommend that, because then one place does have a better view at your medical records as well and can see what other drugs that you're taking and your medical conditions. So when you drop that off, oftentimes the first person looking at it is just making sure there's a lot of legal requirements for what has to be on a prescription. So first they're checking the validity of it. You look very trusting, as are most of our patients, but that's usually kind of that first check, is looking at the validity of it. But when they enter that information into the computer system, they're also looking at any other medications that you're on and could this drug interact with those. And they're looking at any medical conditions they have listed. That's why we always ask, at least annually or sometimes more frequently, do you have any chronic medical conditions? Because you might not have had hypertension the last time we asked, and now you do, and a medication that you're starting might affect your blood pressure. So we're always wanting to have the most accurate records that we have for you in the pharmacy, and so they're scanning that drug and that strength specifically against your age. Sometimes with children, it's more appropriate to check their weight to the drug as well. So there's a lot of just chemistry and math that goes into those analyses before they decide to actually fill the prescription and counsel you on it.
Do pharmacists have access to now, or would they like to have access to the electronic medical records of patients?
So depending on the practice setting, in community pharmacy, that is kind of one area where we're getting better. Oftentimes, a community pharmacy is separate from your physician's medical record or the hospital medical records, so they don't always have full access to labs. We're trying to push to where there would be, one database that everybody could access. It's really hard with patient privacy and the HIPAA privacy regulations where, your physician's office can't share those records and give access to every community pharmacy that you might choose to fill at. So oftentimes we'll be asking the patient some of those questions, or if it's a drug that we're really worried, that medication, maybe your kidney function or some other condition that we're worried about, oftentimes the community pharmacist has to phone the doctor's office and just ask them.
So is that part of the price of drugs? How is the pharmacist time covered for this expertise?
So that is a very complex topic. My personal opinion, I would argue that a lot of the pharmacist time isn't compensated. It depends on how your insurance, if we're billing a prescription benefit manager, your insurance plan, a lot of times the way that the pharmacy is reimbursed is there's typically some type of dollar amount tied to the drug, and then they're added on a dispensing fee. So, and that's going to differ every single patient's insurance plan, what they will pay that pharmacy for that dispensing fee. So covering labor, percent of rent, the bottle and the lid and the labels, all of those things that go into it besides the actual medication, all of that is included in that dispensing fee. But that's all down to negotiation between the pharmacy organization and the prescription benefit manager, what that reimbursement looks like. And so there's been some challenges across the country really with reimbursement that covers even what the pharmacy paid for the drug and sometimes doesn't cover at all the dispensing fee. So it's really contractual.
Well, one of the stories that I've heard from a friend who is a pharmacy tech is how Medicare is now offering to cover a consultation to review medications, but they're only reimbursing pharmacists at $2 for that. And she said, their pharmacy, it's a small community pharmacy, is doing that, providing that service because it's necessary for their patients. But the reimbursement that's offered is insulting.
Yeah, definitely doesn't. We're happy that they're recognizing the value that pharmacists can provide there, but the amount of the reimbursement definitely doesn't cover a pharmacist's time. Medicare is one of those where there's some things that they're covering and some things that we're still pushing for. So on the prescription benefit side and within Medicare, it's called the Complete Medication Review, or a CMR, and they do cover at a small remuneration, but they do allow the pharmacist to go through, and they actually request them to go through a patient's record and really sometimes sit down and do anywhere from a 15-minute to 30-minute meeting with the patient and make sure they understand what all of their medications are used for and how to properly use them, and ask a lot of questions about adherence. Adherence is one of the top wasted healthcare dollars that we have, where people aren't taking their medications appropriately and they end up hospitalized. We would love it if they reimbursed us for our full amount of time and to do those reviews, but we're kind of one of those that we used to always just do some of these things for free. So we're kind of, baby steps. They're recognizing it. They're providing that value. We're still really pushing within Medicare to be recognized as medical providers. We still don't have that on the medical billing side with Medicare. We finally have that now in our state with private insurance, but we still in our state can't bill for our patient care services to Medicare on the medical side.
I think that's just an outgrowth of when insurance was first established. There wasn't a lot that was done pharmacologically. It was herbal and natural, and it was different, and it wasn't the reliance that we have now, especially for some of the long-term chronic conditions.
Yeah, it's definitely changed over the years. One of the courses that I teach, I go through pharmacy history, and my students are always surprised. There was a time when the pharmacist was not supposed to put the name of the drug on the label or tell the patient what it was actually for. And now we have legislation and regulations that have very specific things that need to be on there, and you have to counsel and make sure the patient fully understands. So, we have some catching up to do with some of those other regulations as practice has changed.
I'm struggling a little bit with a cold that just started, and as I was reading all the labels, trying to figure out what of all these multiple choices I was going to give a shot, they say, ask your doctor, and I kept thinking, you really should ask the pharmacist.
Yeah.
Because the doctor probably isn't interested in that conversation.
Well, and oftentimes if you call your provider's office for something like that, they may answer or they may say, ask your pharmacist. So we're starting to see more and more on the labeling, ask your doctor or pharmacist. But pharmacists really are the medication experts, and that's not just prescription. It's those over-the-counter medications as well. They're responsible for all of those medications that are in their pharmacy, and they're a great resource. I often tell people they're highly trained and highly underutilized. And it's, as we have a provider shortage, you have all these highly trained people just sitting there with all this knowledge that they can give to patients, and patients just need to know they can ask.
One of a course that I'm teaching this year to a group of future design professionals, we talk about the difference between a craft and a profession, and that they're both equally valuable kind of sets of skills, but a little different, and that on the professional side it involves absorbing a body of knowledge that will continue to change. What are some of the continuing education requirements that you have to follow as a pharmacist?
Sure, there's a lot. So in our state, every state regulates the pharmacy profession and all their health professions individually, state by state. And so in Washington state, pharmacists are required to complete 15 hours of continuing education every year. And there's also some pharmacists that have credentials beyond their pharmacist license. BPS, Board Pharmacy Specialties, offers a variety of different credentials that you can have, and you have to study and take a really big exam to get those credentials initially. One of them that I have is I'm board certified as an ambulatory care pharmacist. And after taking the test, I have to complete 100 hours of specialty CE continuing education every 7 years to renew.
So what does the ambulatory care specialist entail?
So ambulatory care is anything beyond inpatient, so hospital. So ambulatory care could be a pharmacist working for a physician's clinic, seeing patients, or outpatient pharmacy, your traditional independent or community pharmacy. We kind of separate inpatient and ambulatory care. So there's the hospital specialists, which the medications they need to understand and the services that they provide within that health system sometimes are different than outpatient. We, in outpatient, typically focus on your chronic illnesses and try to help prevent you from being hospitalized. And once you're hospitalized, they're still caring for your chronic conditions, but there's an emphasis on your acute illness.
Boy, a lot of complications there. Let's take a break now, and we'll come back and talk a little bit about what the future looks like for your students.
Wonderful. Thanks.
Hi, this is Kurt Stockwell with Well Dressed Walrus. We are a local website design and development company here in Spokane. What we do is build beautiful, usable websites for local businesses. A website needs to be beautiful, it needs to be usable for your users, your customers, and yourself. Contact us anytime. We'd love to talk with you about your online marketing.
The economy is getting stronger. Banks are lending again, and interest rates are at historic lows. Now is a great time to buy your dream home. The caring and knowledgeable professionals at Homes for You have been helping people just like you for over 20 years. They take the time to listen to what you want and will help you find just the right home in Washington or Idaho. Real estate is what we do at Homes for You, 928-5782, or visit online at homes4uspokane.com.
Okay. Well, you're teaching at the College of Pharmacy.
I am.
How many students at the college typically is it?
So our goal is to have 125 per class in our Spokane campus and then 35 at our Yakima campus. So we always have in each year. So there's 3 didactic years in pharmacy school and then a 4th year where they're on rotations the entire year.
Okay. So that's a lot of new professionals coming out into the marketplace, and that marketplace is changing. And one of the things is that people are now able to go in and actually work with the pharmacist to diagnose some simple UTI, sinus infection, maybe some things that are people know they have, and they kind of know what it is, and they know what kind of care they need. They can work directly with the pharmacist. How is that working out?
So far it's been going great. So we've been able to do a lot of these things in Washington State since the late 70s, but it's really been kind of slow to take off. I think the first thing we really saw was pharmacists providing immunizations. And, when that first started, pharmacists were kind of nervous about it, and the medical profession was a little bit nervous about passing off a part of the care they normally provided. And now it's just commonplace. So we're at that point now where a lot of pharmacists are starting to be involved in what we call minor illnesses and conditions. So if you have strep throat or the flu, they could do a diagnostic in the pharmacy. And then depending on the test results, they can initiate therapy, and the pharmacist can write your prescription for you. We're also having some where it's not a diagnostic. It's the pharmacist doing a clinical assessment. So locally in Spokane and actually across the state, there's different pharmacies where if a woman has an uncomplicated urinary tract infection, she could go into her local pharmacy, fill out some patient information, paperwork, and kind of have a clinical assessment. And if it's appropriate, the pharmacist can write all the prescriptions for her. And there's a list. If you get bit by a dog or cat or human and it punctures where you are at risk and need antibiotics, the pharmacist can assess that as well. If you're stung by a bee and you react to it and have a very large, like over 5 centimeter wheal, like the reaction is large, and oftentimes they'll prescribe prednisone. The pharmacist can do that as well. So we're really looking at this. We're not trying to take away from the medical providers in the area, but we know there's a medical shortage. There's a shortage of providers, and some of these things that we kind of figure are kind of easy and don't need a lot of differential diagnoses. It's pretty clear if it is or isn't. Pharmacists are fully trained to be able to take care of those patients, and then the providers' time, the MDs and the RNPs and the PAs, their time can be freed up for those really complex patients that they need to spend more time with.
So is this something that probably not every community pharmacy is offering that? How does one find out? I mean, you ask your local pharmacist and find out what they're comfortable doing. Is it something they should be able to expect, or?
So my goal is that every pharmacy in our state will be doing this eventually, but you're right. It's kind of pockets right now. Those pharmacies have to go into an agreement with someone with independent prescribing authority, so an MD or an ARNP, and they sign off on these agreements, the collaborative drug therapy agreement that allows the pharmacist to have this authority. So there are pockets of it, and really it's just ask your community pharmacist if this is something they're doing. And if they're not, you can always suggest they should look into it. Feel free to give them my contact information. Okay. I'll help them in any way. That's really what I like to do, is help pharmacists in the community setting advance their patient skills. And but it's going to be pharmacy by pharmacy and on their websites. I know, locally in Spokane, both Yolks and Rosars, as well as the Costco in the Valley, are offering the services. And then there's pockets in Seattle and pockets in Vancouver and Olympia. And then there's a few independents who have started some of the services. But it's really just kind of looking at your pharmacy, if they have a website, and what clinical services they offer.
Is this something that the pharmacies that are doing this, they have an agreement now in Washington State that they can bill it to insurance? Although if someone has a really large deductible, they may actually be better off just paying out of pocket. But how's that billing piece work?
Yeah, so most of the services right now, patients are paying out of pocket for. And traditionally, it's usually around the same amount as an office visit to a provider's office or urgent care, kind of in that range. But we do have a law that passed in 2015 that mandated that private health plans include pharmacists on their list of medical billing providers. And because previously they would just say, we pay you under the pharmacy benefit side, like for the drugs, and they wouldn't pay for clinical services. So it was kind of phased in, and it started to be effective in January of 2017 for community pharmacies. The issue with that is there's been a few pharmacies that have seen patients for a patient visit and medically billed it and been successful in getting that claim reimbursed. But it's kind of been pretty slow. because traditionally community pharmacies didn't have the infrastructure to medically bill. It's completely different than prescription billing. And so a lot of the organizations are looking into computer systems for medical billing, how to properly document for medical billing. And so I think over the next few years, we're going to see this grow substantially as they kind of figure out how to develop their infrastructure to bill. And then we're going to see more and more pharmacies offering the services.
Okay, so this is something that people could tell their pharmacy they're interested in, and just see where they are in the process of going ahead.
Definitely. And I know many of them, will accept your health benefit card for the copay because it is a health service. But they'd really like to be able to bill your insurance for that. I think we see that as one of the major barriers, is that even if they have a copay, if they go to an urgent care, if they know that their insurance is being billed, they'll pick that point of care over going to the pharmacy who's not medical billing, even if their out-of-pocket is similar. Can't really get into the psyche of every patient out there, that if your out-of-pocket is about the same, at the pharmacy, at least right now, there's no bill going to your health insurer. But we're hoping for it to grow. And, we're preparing our students. So WSU's College of Pharmacy is one of the only that I know of right now that requires all of their students to go through a training program for some of these minor illnesses and conditions. Okay. Our state association has a certificate program, and we have all of the students in their second didactic year go through that. So even though it's not current practice now, we're trying to prepare them so when it does become common practice, they're ready.
Okay, so it'll be a piece of expanding healthcare access then, if we can also access through pharmacies. The LSNS Floyd School of Medicine has really emphasized that they're training healthcare providers for rural areas. How is the College of Pharmacy maybe looking towards that mission?
So we've been working with the College of Medicine, doing a lot of interprofessional training with our students as well. And when you look at rural pharmacy, we're reaching out. That's really where you're going to find your independent pharmacy, and occasionally maybe a federally qualified health FQHC, yeah. So the pharmacy's there as well. But really that's your independent. And so we have been reaching out to them because the independents are really the ones struggling on that prescription reimbursement side. And we're seeing nationally more and more closing. And, sometimes they're one of the only health providers in in a rural area. And so we're trying to get them doing some of these services as well. And we had a research project actually where we were going out to rural areas where there might not even be an MD or an ARNP in the area, and the pharmacist truly was for miles the only health provider, and trying to get them to start up some of these programs as well. It's something new, and for some of them it's a little bit scary to learn something new, so we're pushing them towards that and trying to be a support for them as well and help them with implementation of the services.
Kind of switching gears a little bit, the one of the issues with the rural health is it's not just the access, it's the push towards you should just do all this online. Are insurance companies recognizing or starting to recognize the benefit of people having a connection with an actual pharmacist who can provide this kind of enhanced service as opposed to just sticking the pills in the mail every month out of some warehouse?
Yeah, it's kind of twofold. So there are the distribution side of the pharmacy. There's definitely a push towards having it shipped to the patient. But we're also seeing different organizations that are hiring pharmacists to do home visits. And it could be a pharmacist who is not involved in the distribution of their medications, a completely separate company that comes in and does like those complete medication reviews that Medicare covers. And really to go through and sometimes working in conjunction with physical therapy or occupational therapy or other providers and doing home visits and doing a falls assessment risk in that patient's home and going through their cabinets and finding out what old over-the-counter things they have that expired and really doing some direct patient education around their medications. So we're slowly starting to see that, and there's a few payers who are reimbursing pharmacists and for those home visits, but it's still one of those things that's early.
That'll be a complete change from the pharmacist just makes their profit off of filling the prescription and selling greeting cards
Exactly.
to actually being a healthcare provider, and the drugs are just a tool.
Yeah.
And
our profession is excited for it. We've been wanting to be more than the person that puts the pills in the bottle and sell greeting cards, as you said. But really, when you think about an organization, you have to be able to reimburse your time. So now that we're at that point where we can bill for our time as a medical provider, we're going to see, I think, over the years, an expansion of pharmacists into the patient care side. You're going to see when you go to your doctor's office, instead of there being MDs, A&Ps, and PAs, there'll also potentially be a pharmacist. Mm-hmm. And you could be, once you're diagnosed, delegated to see the pharmacist each time you come into that provider.
Right, because you're the ones who are keeping up to date on all
right.
the new drug therapies. And
many of the conditions are medication managed. So the pharmacist really is the best team member, but in conjunction with the rest of that team.
Right.
You need the person diagnosing, you need the patient care. If there's things to administer, you need those nurses in there. None of us is the expert at everything, right? Mm-hmm. So we really need to use every member of the team.
Okay, well, it's going to be some exciting frontiers in the healthcare world to see where pharmacy goes.
Yeah, I'm excited.
Thank you for coming in, Julie. We appreciate it.
Thank you.
Better Health with Lani Madsen is produced in Spokane, Washington by SpokaneTalksOnline.com, which is solely responsible for its content. Better Health is brought to you in part by Sleep Better Northwest. Ask Lani a question, recommend a guest or topic, and hear this program again online anytime at SpokaneTalksOnline.com. Cheers to Better Health, and thanks for listening.